Hello, friends. In the sequence of ENT lectures, I am continuing with the very important topic, which is also very validated in the form of clinical practice also. So let we again continue with this topic of endoscopic appreciation of tympanic membrane and middle ear disorders. So in the previous two lectures of this atlas is freely available for teaching and training purposes, and the copyright claim is also mentioned in the in this video also. So in the first of endoscopic atlas class, we have gone through the canal and the normal tympanic membrane endoscopic appreciation. In the second lecture, we have gone through the traumatic perforation segment of the endoscopic appreciation. Now, in this chapter, we will, in this class, we will go through what kind of changes the tympanic membrane are going to have in an endoscopic examination in case of a acute illness. Acute illness in the sense is we have to consider acute otitis media in this case. So let me take you through. First, let me slightly expand it for better appreciation, and let me shift this. Okay, this is supposed to be a normal tympanic membrane. You can easily appreciate this is the lateral process of the malleus, and there is a cartilaginous cap also on the lateral part or lateral this edge of the lateral process of the malleus. So it is always covered with a cartilaginous cap. This cartilaginous cap is present between this tympanic membrane and the lateral part of the uh, handle of the malleus. So you can easily appreciate also this is cone of light. Cone of light is nothing but the focusing of the light which is thrown through the canal, and it settled down into the anterior inferior quadrant to give an impression of a cone of light. So you can also, if you can closely watch, you can see that there is also some appreciation, or because of the translucency of the tympanic membrane, you can also have a impression of the this long process of the incus. And this is nothing but a chorda, the chorda tympani nerve. This asterisk as number one is nothing but the round window. So here is supposed to be the oval window or the foot plate of the stapes. This will be the round window. So this, in between the round window and the oval window, this will be this prominence is called as promontory. So behind and inferior to the promontory will be the round window, and superior and posterior to the promontory will be the oval window, and here will be the facial recess area in which the cholesteatoma tends to hide. So in the next slide, so this is a routine observation in a normal tympanic membrane. Now we will go through myringitis. What is myringitis? Myringitis word is used as when there is a isolated inflammatory response of the tympanic membrane. The word myringitis, excuse me, the word myringitis is used in order to give a definition when the middle ear is supposed to be normal, and only there is a implication of the tympanic membrane is present. So different types of myringitis or inflammatory sequence of the tympanic membrane are present. By and large, tympanic membrane is always have an inflammatory response when it is associated with the middle ear infection, because tympanic membrane is an extrapolation of the middle ear health. In the previous class we have already discussed. So every inflammatory sequence or a inflammatory response of the middle ear is going to have some kind of a changes on the tympanic membrane. So essentially, a routinely normally healthy looking tympanic membrane rules out any middle ear pathology. So meningitis is when the middle ear is normal but tympanic membrane is involved in a inflammatory sequence. So various type of meningitis are present. By and large, the most common are the viral one. The viral in the sense is usually it's a viral illness, and there is a formation of multiple vesicles and the ruptures, and tympanic membrane crust, and usually there are no changes in the mid layer as such. So this is called as bullous meningitis. Early stage, you can start that there is appearance of a bulla, and suddenly a large bulla is a larger version of vesicle, and it is majority of the time it is filled with plasmid fluid, or a serous fluid, you can say. And the tympanic membrane is having a large bulgy appearance, whereas the mid layer is normal. So this is essentially meningitis is the word is used because there is no implication in the mid layer as such. So this is acute bullous meningitis, and it comes with the patient comes with a painful clinical appreciation, and uh, sometimes fever is also present, but eustachian tube by and large normal. So this is again a very extensive form of you can hardly see any of the important landmarks of the tympanic membrane here. And let me go again. So okay, so you can see this is a herpes zoster oticus. This is a herpes. We have got a simplex infection as well as a herpes zoster infection. Zoster is simplex is usually an innocuous one, whereas zoster is a more serious one or a complicated one. And along with that, you can also have a peripheral facial nerve palsy, because the facial nerve, if you go through the root of the facial nerve, it comes from the it comes from the pons, arises from the pons nuclei, comes onto the CP angle or cerebellopontine angle, enters into the internal acoustic meatus, then transverses the labyrinthine segment and appears in the mid layer. And then it has got two different roots. This is called a tympanic root or the horizontal root, and the vertical root is called as mastoid root. So when there is an involvement of the facial nerve in the mid layer, then you will obviously have a peripheral in the senses when there is a implication on the facial muscle periphery. And central is when we have got a tumor or a basal dysplasias or tumors of the central nervous system, that will be a central nervous system or a higher palsy. So in case of a peripheral palsy, along with the tympanic membrane inflammation, is called as Ramsay-Hunt syndrome. Very important. This is herpes zoster. It is a inflammatory sequence of a herpes zoster virus. Oticus stands for the ear, and along with there is a peripheral facial nerve palsy. So this is a syndromic appearance, bimodal syndromic appearance, in the sense that first of all we have got a herpes zoster inflammation, and along with that we have got a involvement of the seventh nerve or the facial nerve, and you have got a facial nerve palsy. So this is a Ramsay-Hunt syndrome, very important. So this is a granular meningitis. Again, most of them are viral disorders. So these are not again so very common. Most of the tympanic membrane inflammatory sequence are usually as a result of middle ear infection. So again, this is a granular meningitis. It's a kind of a autoimmune response. Many of people also claim about this, being it is a autoimmune response. So this is the topic we are now focusing on today. This is acute otitis media. What are the clinical explanation, and what are the actually endoscopic appreciation, and what are the endoscopic changes? Because nowadays endoscopy is so very common that every year you examine in your OPD. This was done with a otoscope, handheld otoscope, which has got a self-illuminated battery. And but nowadays it is almost everywhere is replaced by a endoscopic examination. So you have to be a very good in, you can say, about what kind of a changes in a endoscopy you are going to have in different disorders like perforations, or acute or a chronic otitis, or a cholesteatoma of the ear, or canal disorders. So this is a very routine practice, and even for the undergraduate students, it's almost mandatory to have a what kind of a endoscopic changes different disorders are going to have. So this is a acute otitis media case. Acute otitis media we have already encompassed, and we have already completed in previous classes. Acute otitis media is a acute inflammatory sequence of the middle ear. Middle ear is filled with transudative and exudative fluid, and the middle ear mucosa is by and large undergoes inflammatory sequence. There is a some fluid collection also. So everything which is going on in the middle ear is also going to be expressed or visualized on the tympanic membrane also. So giving a good look of the tympanic membrane by and large gives you a good amount of knowledge or what kind of a health the middle ear is going to have of the patient. So it is essentially the endoscopic examination is essentially not a tympanic membrane examination, but also examination of the middle ear components, its ventilation part and retraction part and pathology and hearing loss. You are going to have much of a larger picture if you complete a good endoscopic examination. So you can say that this is a hazy tympanic membrane. The handle of malleus is not visible, and by and large this is a bulgy kind of a bulgy and a edematous and congested tympanic membrane. And the patient, what are the clinical presentation? The patient usually comes with a otalgia. What is otalgia? Otalgia is painful ear, pain in the ear. So if the patient comes with a pain in the ear, some febrile in kids or pediatric population can have a vomiting episodes also, and in severe disorders you can have a mastoiditis as well. So this is a picture of a acute otitis media stage in the middle ear, in which middle ear is acutely inflamed. So what are the clinical examination in endoscopy? Loss of various landmarks of the tympanic membrane, loss of cone of light, handle of malleus. By and large, the tympanic membrane will be angry or congested, you can say. Next picture will again, excuse me. Yeah, this is again a excuse me, acute otitis media. Another picture. You can see there is no there is bulging of the posterior quadrant also. There is corrugation of the corrugation in the senses. The pars tensa is not so stretched, and the handle of malleus is embedded also in the edematous tympanic membrane, and some part of the tympanic membrane comes out also. This is called as bulging, which is opposite to the retraction. Retraction of the tympanic membrane is suggestive of negative middle ear pressure, whereas bulging is suggestive of some fluid or a serous fluid or a inflammatory fluid or a exudative fluid is pushing the tympanic membrane laterally. So this pushing or bulging can be a future perforation also in most of the cases. So this is a you can say in the literature also that reveals a purulent middle ear effusion. The patient also will have a painful ear as well as the heaviness as well as the hearing loss also, conductive hearing loss as well. And the tympanic membrane is erythematous. Erythematous is edematous or congested. So this is again a very common picture of the tympanic membrane. Let me centralize it. Okay, you can see that this is a, sorry, okay, give me a minute. Oh, okay, no. Let me take you to this okay, this is again a normal tympanic membrane. We have already gone through. Okay, otitis media with effusion. Effusion, no, we have to go first through the acute ear. So that was the previous slide. So let me some kind of picture if you can appreciate what is this. This is a case of a acute otitis media in a pediatric population case with a mastoid air cell as well, which leads to a post-auricular large swelling also, and there is a of the mastoid, and there is forward bulging of the or pressing of the pinna to anteriorly. So this is a complicated otitis media, acute otitis media, with a suggestion of mastoiditis or acute mastoiditis. These patients comes with a either a discharge or a pain is always there, and you can't even see the tympanic membrane in this case because of the forward bulging. There will be sagging of the posterior canal wall. It's difficult to insert an endoscope in these case patients, and you have to use a small pediatric endoscope in these cases. So this is a previous acute otitis media presentation, and if the patient is not responding with antibiotics, and the fever is not going down, the patient is not responding, then the patient can complicate. We have already gone through the complication of acute otitis media and chronic otitis media in a separate class. So this is ultimately is called as acute mastoiditis. These patients has to be admitted, and in order to look at whether there is a complication in the temporal restricted temporal bone, or it has disseminated to the central nervous system also. So you have to have also a HRCT or a high resolution CT scan also. So these patients need to be admitted and put on an intravenous antibiotics, and had to be evaluated for CNS sinus central nervous system science also, in order to look for the meningism. Meningism is meningeal irritations. So you can easily appreciate this that there is a bulging of this right side of the pinna, forward pushing of the pinna, and there's an involvement of the mastoid air cell cortex region also. Air cortex in the sense is every cell of the middle ear as well as around it is involved, and the patient is having a by and large a coalescent mastoiditis in few cases, when all of the air cells in the temporal bone behaves as a single cavity and filled with a mucopurulent discharge. And ultimately, if the patient do not seek treatment, then you can have a discharging cutaneous fistula or a mastoid fistula on the skin also. So you can easily see that there is a variety of complications which can happen in case of a acute otitis media or involvement of cholesteatoma. So this is again a very common endoscopic picture. We have gone through acute otitis media picture. We have seen that there will be edematous canal, there will be congestion on the tympanic membrane, loss of this, you can say the landmarks are there. So this is a picture, clinical picture, very common clinical picture of otitis media with effusion, also called as glue ear. So this starts with a negative pressure in of the tympanic of the middle ear as a result of blockage or closure of the eustachian tube, which leads to negative pressure in the middle ear, which sucks out plasma from the surface mucosal capillaries. And this fluid which is collected in the middle ear is not infected, it's a sterile fluid. So the patient will not have a pain, but certainly have some degree of hearing loss in the vicinity of 35 to 45 decibel. And he comes with a hearing loss and a sense of heaviness also. So you can see these are entrapped air bubbles also in the exudative fluid also this serous fluid which has comes out from the capillaries of the tympanic of the middle ear mucosal vessels or capillaries, entraps some air bubbles which are, you can easily appreciate, are so near to the eustachian tube also. So some air bubbles are entrapped. So this is a called as a air fluid level, you can see. So these presence of air fluid bubbles and this amber looking tympanic membrane. So this is not a translucent tympanic membrane now. So a good endoscopy, you need not to have a tympanometry even if you diagnose the patient well in an endoscopic appreciation, as well as get a pure tone audiogram, that is called as hearing assessment done. Then you can easily go for a surgery. In this case, you have to make a window in the posterior inferior quadrant. No, not posterior inferior, and the anterior inferior quadrant, because posterior inferior has got we have got some important structures here. So in order to remove this fluid, we have to make a window in the inferior quadrant. This is called as tympanotomy, and we have to insert a ventilation tube. This is a very routine procedure. Every ENT surgeon starts with this kind of a easily operated surgical intervention. And you can remove this, suck out this fluid, and put a ventilation or a grommet tube in order to ventilate the ear, which also prevents further blockage or collection of the serous fluid in the middle ear. So this is again otitis media with effusion. Effusion is again a negative pressure. You can easily see some bubbles also entrapped in the serous fluid. This is again a third picture. Very clearly you can see these air bubbles are entrapped in the serous fluid. So if there is appearance of the secondary infection or bacterial appearance in this ear from secretory otitis media or otitis media with effusion, we have got three names for acute otitis media with effusion. Number one is acute otitis media with effusion. Number two is secretory otitis media. And number third is glue ear, GLUE, glue ear. So this ear, if this is a sterile fluid, obviously when it undergoes a bacterial appearance, can also behave as a acute otitis media, the painful picture, and then it will automatically or physiologically you can have a perforation in this case. So this is again a effusion case. This is a retraction pocket. Retraction, this is a good case of a retraction. The anterior segment of the tympanic membrane seems to be normal, but the attic part you seems to be retracted or medialized. Medialized, and the posterior segment of the tympanic membrane is plastered on the long process of the incus. So this leads to also a conductive hearing loss, and there is a long-term association between the tympanic membrane and this long process of the incus. Then it starts eroding the long process of the incus. So majority of the retraction pocket cases or retraction cases, there will be the avascular necrosis of the long process of the incus, and there will be again a discontinuation of the ossicles, and the patient will have a conductive hearing loss. So this is again a very initial kind of a, you can say, this retraction. So this is again a amber color looking tympanic membrane. Another picture, there is a vascular congestion of the inferior quadrant. This is a long process of the incus. This will head out the stapes. So by and large, absolutely, this is a clear cut endoscopic, very common appearance of the blue ear or a secretory otitis media with effusion pathology. So we will discuss about probably the last one is the remaining topic for ENT. We have gone through the modern otology, right from the anatomy to physiology to middle ear anatomy. Then we have moved on to the acute otitis media, secretory otitis media, chronic suppurative otitis media. We have done cholesteatoma in 2 classes. We have gone another lecture for complications of the chronic suppurative otitis media. We have already discussed about safe and unsafe here. We have already discussed about some surgical aspects also. So one or two topics are remaining. Perhaps one is otalgia and the second one is tinnitus. After these two topics, we will complete this modern otology segment, and then we'll move on to the literary part of the Ayurvedic concepts. Thank you. Thank you for watching. Thank you.